component of action plan, that is suicide prevention. And this is being organized by IAP Kerala and Adolescents Health Academy, and it is hosted by IAP Calicut. And I am privileged to welcome all of you for this function. I welcome our State President, Dr. T.P. Jayaraman, and who conceived the idea of this action plan and working on it. Welcome, sir. And today, our chief guest is none other than respected MKC, sir, who was the first national president of IAP from Kerala and have done a lot of work in the field of adolescents and also worked as the Vice Chancellor of Kerala Health University. Welcome, MKC, sir, for this program. And today we have Dr. Shibu Kirakatra, who is the chairperson for IAP Adolescent Health Academy. Welcome, Dr. Shibu, for this function. For felicitation, we have Dr. Vijay Kumar M, who is the President-elect of IAP Kerala 2022, and also Dr. Narayanan, who is the immediate past President of IAP Kerala. Welcome, Dr. Vijay Kumar and Dr. Narayanan. And we have Dr. Johnny Sebastian, Secretary, IAP Kerala. Welcome, Dr. Johnny. And we have Dr. Ranjit, who is the convener for this suicide prevention program. Welcome, Dr. Ranjit. And we have the treasurer of Adolescent Health Academy, Dr. Deepa Janardhanan, and Sri Nandajan, clinical psychologist from Palakkad, who is giving a talk on suicide prevention. And also we have senior faculties, Parvati Madam, Dr. Abhiram, Dr. Binoy, Dr. Mukesh, Preeti Madam, Dr. Vishnu. I welcome all, and also Dr. Ajay, who is the Secretary at IAP Calicut branch. Welcoming all once more. Thank you.
I would like to welcome our AHA Kerala chairperson, Dr. Shibu Kirkatra, for the presidential address.
Thank you, Dr. Ranjit. Respected Dr. MKC sir, Jairam sir, Vijay Kumar sir, Narayan sir, Mohandas sir, Tony Sebastian sir, Dr. Ajay, Dr. Ranjit, Preeti Madam, and all respected dignitaries. Today we are going to share the official inauguration of suicide prevention and adolescent. That is one of the IAP Kerala Presidential Action Plan 2021. And the theme is, as you want to tell us something, we have enough time to listen. Let me invite Jairam sir, President IAP Kerala, for addressing the delegates. Jairam sir, please.
Good evening, everybody. Respected President of IAP Calicut, Dr. Mohandas, President Adolescent Health Academy Kerala, Dr. Shibu, Doyen of Adolescent Pediatrics and past National President of Indian Academy of Pediatrics, past Vice Chancellor Dr. MKC Nair, Dr. Ranjit, Secretary of Adolescent Health Academy, Dr. Narayanan, past President of IAP Kerala, Dr. Vijay Kumar, President-elect and Action Plan Coordinator, Dr. Johnny Sebastian, Secretary IAP Kerala, Dr. Ajay, Secretary of IAP Calicut, Dr. Preeti Galgali, the National EB member of Indian Academy of Pediatrics, Dr. Parvati Madam, all the other dignitaries on the platform. It gives me immense pleasure on this day to launch this important the action plan, which IAP Kerala is doing along with the help of Adolescent Health Academy of Kerala State. Actually, this was one of the first action plans which we had envisaged for the year. And Ranjit, I thank Dr. Ranjit, Dr. Deepa, Dr. Sri Prasad, Dr. Shibu, and all others in AHA, and also Dr. MKC Nair sir, who did the final review of the manual, as well as Dr. Nandajan and Dr. Vijida, two psychologists who are active in the field of adolescent prevention for the last 3-4 years. And I'm so happy to launch this program on this important social issue among our adolescents. And I don't want to stretch more, because Dr. Ranjit will be briefing on the action plan as such. I wish the very best for the program, and I thank IAP Calicut and Adolescent Health Academy for giving me a platform to launch this important action plan. Thank you so much.
Thank you, Jairam sir. Next is the official inauguration of the program. For inauguration, we have none other than respected Dr. MKC sir, former Vice Chancellor PUFAS, past National President of IAP, NNF, and Adolescent Health Academy. I invite respected Dr. MKC sir for inaugurating the session.
So, most respected President of IAP, Jayaraman sir, past President Narayanan, Dr. TV Ravi, NNF current NNF President, Dr. Shibu from AHA, Mohandas sir, Johnny, all other people, Preeti Galagadi for our guest speaker, and most important senior Dr. Parvati Madam, Ranjit, all other dignitaries. 3-4 things, not 3, I'm going to say 6 things today, because the first point that I would like to say is suicide is the most distressing thing that can happen to a family. It is like a missile attack to the family. I mean, simply, unless we have faced it, we will never understand the ramification of it for many, many, many months and years. So it's a very huge tragedy, an attempt. It doesn't have to die. Attempt is death we may accept even more, but attempt is the most distressing, because you never know. Parents are worried when exactly is going to happen again. So that is the most important. In the recent past, I have actually been directed to see these children. We have a very competent clinical psychologist, but my new hospital MD has asked me that you should see all the cases. And a lot more information that I'm learning now from whatever I have done in the last 40 years, much beyond that. There are a lot of theories on, as usual, we have in a module, we'll put all sort of ideas, theories. But the fact is there are a lot more truth beyond the theories. These theories work in general, doesn't work for that individual child or individual family. That is something we need to be very clear about it. That particular thing that we are looking for in the family is entirely different from what we have learned or what we are trying to teach you. The most important lesson I have learned, and that we all know, that depression is an important precursor for suicide. If you ask what are the causes of suicide, number one, I will say depression. Rule out depression. That is the most important thing. But recently, we have also realized that just like depression, anxiety is also a most important. In fact, we have done a beautiful study in Kerala only, without telling which place. 500 randomly, systematically selected adolescents. We have published this, where we have found about 23-24% having anxiety, serious anxiety symptoms in normal children, and many of them, 1/4 of them also having concurrent depression, and both are leading to suicidal ideation. So that is something we need to really think about it. But the good part is both can be treated by the same drug, fluoxetine, 10 to 20 milligram in the morning for the depression, 20 to 40 for the anxiety. That's all. Little dose more for the anxiety. But even more important than that is the theme or the message of this program. If you have something to tell us, we have the time, which means very important. We are there to support you. That phone number is extremely important. But the time we spend with the child has to be quality time. Because you can sit with a person, talk a long time trying to sympathize, and we say we try to empathize. But what is important is that crux is that you are able to make that child feel that I am there for you. And for that, little amount of counseling training may be required. And probably we cannot do with this module everything, but this is a beginning. This should be followed by a better, little more serious counseling training. Fortunately, suicidal attempt is not medical legal. I have little doubt in the module. I have put an arrow, just check on that. It is written medical legal. When you took the steps, I'm not sure whether you need to inform police for this one. I don't think so now. Just but in the module it has come like that. I didn't change it because I put an arrow just to see whether you check on that. Because somebody who wrote it probably thought of it and wrote it. So I didn't want to change it. But I think the best thing that has happened in this country is that you are not penalizing a person. A person trying suicide is out of desperation. Now you don't want to put him into police case also on that. So, but death of course will be definitely medical legal, but attempted suicide will not be. So my best wishes to the Presidential Action Plan. And I really would like to thank both IAP, NNF, and I see Ravi somewhere. Yes, Ravi is here. Also, the Adolescent Health Academy, Dr. Shibu and his team. Thank you. Thank you all very much.
Thank you, Dr. MKC, sir. Next, for felicitation, I invite Vijay Kumar, sir, President-elect IAP 2022.
Respected MKC, sir, Preeti Madam, Dr. Jayaraman, President of IAP Kerala, Dr. Narayanan, past President, Dr. Shibu, President AHA Kerala, Dr. Ranjit, Dr. Johnny, Secretary, Dr. Ravi, and all other faculty and all other seniors. And suicide is in some textbooks say suicide is the second commonest cause of death for adolescent and young adult. And as sir was telling, if a child commits suicide or if there is trying to get a suicide, I think depression is the most important underlying cause. And we have to prevent suicide by finding out the exact etiology. And for this is a novel idea of IAP Kerala to include the suicide prevention in adolescents as one of the action plan of this progress. I wish very best for this novel program and all success. Thank you.
Thank you, Vijay Kumar, sir. Next, I invite TV Ravi, sir, NNF President Kerala, for felicitation.
Good evening, everybody. Respected MKC, sir, my friend TPJ, and office bearers of IAP Calicut. It's indeed a pleasure to join this meeting today on a very important.
Not audible.
Am I audible?
Yes, yes.
Yeah. It's indeed a great pleasure to join this meeting on a very important topic, that is the suicide prevention, which is one of the most important agenda in TPJ's Action Plan 2021. Nowadays, in media and in the visual media and print media, we hear a lot of sad stories about teenagers committing suicide. So we need to probe into the actual reason for what leads them to do this, and we should take proactive measures to prevent this catastrophe. And I think it's a good beginning on the part of TPJ to take up this task by way of creating awareness among the pediatricians so that they will play a vital role in counseling the teenagers as well as those who are prone to this suicide tendency. I wish this scientific deliberations all the very best. Thank you very much.
Thank you, TV Devi sir. Next, I invite M. Narayan sir, past president IAP Kerala, for felicitation.
Good evening to you all. Respected National President MKC sir, then dear presidents Dr. Jayaraman, Dr. TV Ravi, Dr. Vijay, Dr. Mohandas, then Secretary Dr. Joni, Dr. Ranjit, Dr. Shibu, Dr. Deepa, and the senior pediatricians and friends. First of all, congratulations to IAP Kerala, Dr. T.P. Jayaraman and team for selecting this important topic as an action plan, and Calicut branch for organizing this function. If you go through the figures of number of suicides from the Crime Bureau of Kerala State, there is a point of relief that during the last 6 years, from 2015 to 2021, during the last 6 years, there is a steady but gradual decline in the number of suicides from adolescent suicides, from 330 to 250. That is happening despite the increase in population and despite the increase in the abuse of mobile phones and other social media. So something is working in the positive direction. Now, when we look at this point, apart from the number of suicides, there are other two groups who have attempted suicides, and a larger group who always threaten to suicide. These two groups are also there. And definitely IAP can do a lot in this to help these children. And I would suggest that this program should be school-centered, because the best persons to spend more time or spending more time with school children are the teachers. So they will be the best persons to pick up depression, anxiety, everything at the earliest. So as Calicut has been doing in the past, we should conduct programs for the teachers and the NSS coordinators and volunteers, because during last year and all, we had a huge attendance to the tune of more than 500 for Zoom session from these groups. So that will help our program to reach the target group, that is our dear children. So wishing this program and this webinar all success. Thank you.
Thank you, Narayan sir. I invite Preeti madam, past national president, Adolescent Health Academy, for felicitation. Preeti madam.
Thank you so much, Dr. Shibu. And thank you, Dr. Jayaraman, for inviting me on this very special occasion. And I'm so happy that MKC sir, my teacher, is here, and all the stalwarts of IAP Kerala. We started this Mission Kishore Uday, the central IAP program focusing on adolescent suicide and prevention in 2018 and 2019 under the IAP Presidential Action Plans. And MKC sir was also the guest editor of the module. So I'm extremely delighted that you're carrying on the suicide prevention message with a strong focus on talking and listening, because we know that most of the adolescent suicides are impulsive in nature, and the talk and the connect can actually save the life of a child. Yes, adolescent suicides is the #1 cause of adolescent mortality in India. And we as pediatricians have to take this on a much larger scale, because adolescents and their families simply love us. They would rather come to us than a mental health professional. So I wish this program the very best. And as said by Dr. Narayanan, I hope you will take it to the community, to the adolescents themselves, to the teachers, the parents, and build resilience. And resilience is the need of the hour, most so in the COVID-19 pandemic, for our adolescents and for us even. Thank you very much.
Thank you, Preeti Madam. I invite Joni Sebastian Sir, Secretary IAP Kerala, for felicitation.
Respected Chair Mohandas Nair Sir, President IAP Kozhikode, Chief Guest of the Day and Don in the field of adolescent pediatrics, Professor MKC Nair Sir, past National President IAP and NNF, my leader and IAP Kerala President Jayaraman Sir, Dr. Preeti Madam, Dr. Ravi Sir, NNF President, Dr. Vijay Kumar Sir, President-elect, Dr. Shibu Sir, Chairperson AHA, Dr. Narayanan Sir, immediate past President IAP Kerala, my friend Dr. Ranjit, Secretary AHA, and Dr. Deepa, Treasurer AHA, other dignitaries and seniors on this platform, and dear friends. At the outset, let me congratulate AHA Chapter IAP Kerala for bringing out this excellent module on this Presidential Action Plan, a very important and a very useful one in the present circumstances. As you all know, a lot of psychosocial issues are going on in the current pandemic situation. I would also like to congratulate IAP Kozhikode for hosting the launch of this Presidential Action Plan. Adolescent suicide, I feel, is ultimately a result of an adjustment disorder, which leads to anxiety as well as depression. The process of adjustment, as we all know, on its own is accompanied by stress and by physical and psychological dysfunction. And so we need to recognize those atypical signs of depression in adolescents, which are not very typical when we see, as we see in adults. So if we are able to recognize those signs of depression early, we can prevent a good number of suicides. We have very good speakers today to enlighten us on these topics. I wish this CME all success. Thank you. Jai Hind, Jai IAP.
Thank you, Joni Sebastian Sir. Now we can start the scientific sessions. First, we have introduction of the module by Dr. Ranjit P, Chairperson, Suicide Prevention in Adolescents, and Ranjit, Web Editor of IAP Kerala and Dynamic Secretary of FAHA Kerala. Over to Dr. Ranjit P.
Good evening, my respected teacher and our chief guest MKC sir and Preeti madam, who inspired us the field of adolescent pediatrics, and our state president Jayaraman sir and Joni sir, Vijay Kumar sir, and all my teachers. I am presenting the introduction of our adolescent suicide prevention module, which is reviewed by our great teacher MKC sir. Is the screen visible?
Yes, yes.
Yes.
So, suicide prevention in adolescents, it is the one of the major action plan of IAP Kerala 2021, which why the prevention is so important. So we all know that in our country, one adolescent die by suicide in every 1 hour. The age group most commonly affected is between the age group of 14 to 25 years. And compared to our southern states having more suicide rates compared to the northern states. And among the statistics, Kerala ranks 4th in the suicide rates of adolescents. Of the country-wise, India stands 3rd in the world annual female suicides and 4th in the male counterpart. And 1/3 of all suicide in our country belonging to the adolescent age group. So Narayan sir mentioned about the recent Kerala statistics, and we know it is gradually decreasing, but minimal decrease is there. In 2017, there was 229 child and adolescent suicides were there. In 2018, 203 deaths in between the age group of adolescents and child age group. 215 were the statistics of 2019, and up to August 2020, there was 178 child and adolescent suicides were there. The source is State Crime Records Bureau. And whether the COVID lockdown secured our adolescents. So we know that from the statistics, there is no much decrease in the number of child suicides in Kerala, even though we feel that child are safe and in the custody of our parents, custody of the parents. And when analyzing the suicide rate, it is more common in the lower and middle income groups. More than 91% belongs to that group. And the children who ended in their life, out of which the 50 children who ended their life were said to be good in the studies. In the statistics, one got award from the president for President Scout Award. Another was a student police cadet. These are the statistics from DGP Srilega, who constituted a committee, who was the head of the committee constituted by the government of Kerala. And the teachers and parents never addressed the issues of active or smart children, assuming that they are all well in their academic and also in the extracurricular activities. And most of the children who died by suicide studied in the government school, about 48%, and 30% studied in the government aided school. And out of a total of 108 children who died by suicide were in the age group of 15 to 18 years, out of which the 66% belongs to the girls. So what is the importance of this module? Why the pediatrician should be trained? So the adolescent suicide is really preventable if they seek medical professionals help early. And as we all know, the health seeking behavior among adolescents is very low. As the pediatricians were the primary care physicians of the children and adolescents, if we are trained, we can recognize the early warning signs of suicide, and we can save 4 out of 5 children which shows the warning signs of suicide. And we know the adolescent friendly mental health facilities in our Kerala is also less, and there is programs coming to prevent the adolescent and friendly mental health services in Kerala with the implementation of RKSK and other facilities. And social stigma even in the educated and upper class families to seek professional help also still there in the Kerala. So training pediatricians in this aspect will be a real help to address this issue, and we can reduce the suicide in adolescents and child. The phrases like committing suicide or successful suicide is no longer used by the researchers and pediatricians. That phrases should be discouraged as they carry negative blaming connotations, and it may mislabel the suicide behavior as that is successfully accomplished. So we have to use the terms like die by suicide or completed suicide, which is more acceptable. The reference is Indian Pediatrics May 2020 journal. So why the adolescents, the suicide rate is more common. As we all know, adolescents are having full of energy and intense emotions. They have selective ways of thinking, and they have different ways of handling the issues. And due to this reason, when adversity strikes, they fail to handle the situations, and they may resort to destructive acts like suicides or substance abuse. What do you mean by the suicide? That is conscious act of self-induced end of life by an individual who perceives this act as the best solution for his all stresses or any problems. It is a way out of problem or crisis that is invariably causing intense suffering, and they feel that they have the feeling of helplessness and to cope with the unbearable stress, and they need to escape from the situation. Apart from the normal pressures of teen life, specific circumstances can contribute to adolescents thinking of suicide. And if the problems are out of their control, they will commit suicide. So we have to identify the risk factors for the suicides. There is individual risk factors, that is the poor self-esteem, any history of previous suicide attempts, alcohol or drug abuse, if there is any failed romantic relationship, mental health disorders, chronic disease, recent loss of near and dear ones, Is there any sexual identity confusions and shame? Easy access to lethal weapons and pill, and hesitancy for seeking help. Family and social factors. If there is any family history of suicide, if there is any disrupted family environment, if there is any financial crisis, if there is an alcoholism in parents, if there is any domestic violence in the family, if there is a sexual abuse from their dear ones or family members or others, if there is bullying or ragging, if there is humiliation by teachers, if there is punishment or poor discipline methods, any poor academic performance. These are the family and social factors which contributes the adolescent suicides. Coming to the societal factor, lack of awareness about the support of medications or mental health facilities, and less number of mental health professionals, inaccessible, unaffordable services of mental health. If there is any social stigma associated with mental health disorders, it is still prevalent in our Kerala. If there is any cyber attack, harassment, over support from the healthcare workers, unfriendly teenage care services. These are the societal factor which contributes to the increase in the adolescent suicide. If we can sense someone having suicide tendency, it doesn't just appear out of the blue. The people usually display a number of warning signs of suicides. So, what are the warning signs we have to look for? Withdrawal from the family and peers, loss of interest in the previous pleasurable activities, difficulty in concentrating on schoolwork, neglect or personal appearance, obvious changes in personality, sadness and hopelessness, changing in the eating patterns like sudden weight loss or sudden weight gain. These are the warning signs. And changes in the sleep patterns, general lethargy or lack of energy, symptoms of clinical depressions, violent actions or running away from the problems, recent drug and alcohol abuse, symptoms that are often related to the emotional state, like not related to the emotions like headache, fatigue, stomachache, loss of ability to tolerate praise or rewards. So we have to differentiate between the depression and feeling blue, that is the sadness. We all know the clinical depression. It is a mental illness which needs treatment. As we mentioned in the earlier stage, there was multiple emotional, behavioral, physical, social, and factors which influence depression in adolescents. The duration of depression can lead from 2 to 6 weeks, or it may last more than 6 weeks. In depression, the suicide potential is very high. In that scenario, we have to give them a psychotherapy and specific medications. That is the importance. We have to recognize depression and we have to refer for the treatment, as it has increased suicide potential. And the duration is it will extend more than 6 weeks, or it can be between 2 to 6 weeks. Sadness, as we all know, it is mood swings normal in the teens. The symptoms may be a single, mainly sad mood. It can be a transient, a brief period. The symptoms of sadness may persist. It can rarely be leads to suicides, and we can treat the child. We can respond to simple confiding to a good. We can behave like a good listener, and we can divert them into a positive activity. We can teach them life skills, and we can give them counseling if the sadness is lasting more time. What is the major signs of depression? These are the major signs, that is worthlessness, hopelessness, helplessness. That is, എന്നെ കൊണ്ടൊന്നിനും കൊള്ളില്ല, എനിക്ക് എല്ലാ പ്രതീക്ഷയും, എന്നെ കൊണ്ടൊരു കാര്യമില്ല, എനിക്ക് ആരെയും സഹായിക്കാനില്ല. ഈ 3 തോന്നലുകൾ വന്നാൽ തന്നെ അത് ഡിപ്രഷന്റെ മെയിൻ സിംറ്റംസ് ആണ്. And also increased irritability, emotional outburst, moodiness, anger, frustration, frequent absence from school, poor concentration, restlessness, episodes of crying and anxiety, loss of interest in previous enjoyable things, aches and pains. There is loss of change in the sleep pattern and eating pattern, recent alcohol or drug abuse. These are the main signs of depression. As mentioned by MKC sir in the inaugural speech, study on depression and plus anxiety and suicide. That was a study conducted in South India. The prevalence of anxiety disorders among rural adolescent population in South India was around 25.8, using Indian scale, that is a scale for anxiety related symptoms. The same study showed that depressive symptoms are also present in 23.7% of adolescents with anxiety disorders. So they are also having depressive symptoms also there. Suicide behaviors were increased by presence of anxiety disorders. And also being a boy, there is increased risk of suicide behavior associated with anxiety disorders. It is an important study. So it shows that 25.8% there is prevalence of anxiety disorders among rural adolescent population in South India. This is an important teen screening questionnaire of mental health, and it is published in the Indian Psychological Journal. It is by our respected MKC sir and Babu George sir. They had developed this questionnaire. This is a simple questionnaire to identify the mental illness in adolescents and children. There are 7 questions. Have you ever felt this? If there is, have you ever felt anxious, sad, angry, or irritable, stressed, or tension? Do you feel your symptoms are out of proportion to cause? We can tick that is no, yes, not applicable. Do you frequently have any of the following symptoms in the recent past? That is, if there is no symptoms, we can write it as none. If there is palpitation, 1. Excessive sweating, 2. Appetite significantly less or more. Sleep significantly less or more. Sexual interest significantly less. These are the questions. And do the above symptoms disturb your daily activities? If there is no disturbance in the daily activities, we can mention it no. If it affects the studies, it is 1. If it affects the job, it is 2. And have you lost interest in the things you have previously enjoyed? So also we have 0, 1, 2 questionnaire. These are the main symptoms of depression. That is, you are good for nothing. That is worthlessness. There is no future for you. Hopelessness. You can do nothing in life. Helplessness. It's also a simple questionnaire. The child can tick never, 1, often. Life is not worth living. Never, sometimes, often. Want to harm yourself. That also, if the child answers, we can diagnose. And based on this questionnaire, we can identify the anxiety, depression, suicide tendency, and other mental health disorder. This is a simple questionnaire we can practice in our clinical session with adolescents. What are the do's and don'ts for parents, teachers, and peers? The do's. We have to show concern over the adolescent's problem, and we have to show empathy. And we have to directly ask if there is person had made any suicide plan, any other plan, and inform parents. If there is such a plan, we have to inform the parents immediately. And we have to take urgent professional help if the child have any suicide ideation. And we have to go to they have to go to a mental health facility. We have to refer to a mental health professional who having experience in treating such cases. The don'ts, we don't have to take it lightly. We don't have to laugh, joke. We don't have to challenge the person. We don't express as shocked. We don't have to argue or debate about the moral issues and reasons. And we don't give a false promise that we will keep it as a secret. We have to inform the parents on the suicide ideation. And for media, we all know the media is glamorizing the suicide. There was a lot of discussion whenever Sushant Singh Rajput was committed suicide. There are so many mode of suicide, and in the front page also media was covering so many suicide ideations. So media should be sensitive, responsible media coverage should be on suicide. Don't glamorize the suicide. Don't provide simplistic explanation. Avoid excessive detailing of the suicide method. And media have to present suicide as a bad choice to resolve the crisis. So what is the role of IOP? The role is we have to sensitize our fellow colleagues, pediatricians and general practitioners the importance of the suicide prevention, and we have to teach them the warning signs. And the trained pediatricians can conduct awareness programs through district RKSK coordinator, Rashtriya Kishore Swasth Karyakram coordinators, which mainly focuses on the adolescent health. And we have to sensitize the PTA, Saufrada Club, which is run in all the government schools by coordinating with the district IAP. We had to give sensitization to the parents, teachers about this preventable cause. IAP can act as a technical and advisory support to government in adolescent health program through district RKSK program coordinators. We had to offer a helpline or support group in each district with interested pediatricians, psychiatrists, psychologists, and school health counselors. So, as a part of the IAP Action Plan 2021, suicide prevention, we are planning 3 zonal trainings for pediatricians and general practitioners. In North, we are planning to conduct the program in IAP Pariyaram, Central IAP Valluvanad, South IAP Alappuzha. So this is our theme for this program. We have something to tell us. We have enough time to listen. നിങ്ങൾക്ക് എന്തോ പറയാനുണ്ട്, എനിക്ക് കേൾക്കാൻ സമയമുണ്ട്. നമുക്ക് ആ സാഡ്നെസ്, കുട്ടികളുടെ സാഡ്നെസ് അല്ലെങ്കിൽ സൂയിസൈഡൽ ഐഡിയാസ് കേൾക്കാൻ നമുക്ക് സമയമുണ്ട് എന്നായിരിക്കണം നമ്മുടെ ആദ്യത്തെ മനോഭാവം തന്നെ. അപ്പൊ അതാണ് നമ്മുടെ ഈ സൂയിസൈഡ് പ്രിവെൻഷൻ പ്രോഗ്രാമിലെ തീം. ദിസ് ഈസ് അവർ മോട്ടോ. ആൻഡ് ദർ വാസ് എ ഓർഗനൈസേഷൻ നെയ്മഡ് ചങ്ങാതി വിച്ച് ഈസ് run by our state president, Dr. T.P. Jayaraman, and also our guest speaker, Sri Nandajan, who is the president of this organization. They're regularly doing adolescent suicide prevention programs from 2019. We had done so many sessions, about 6,000 children where they had covered. So we included them also as a part of the presidential program. So the contributors for this module, that is our respected teacher, MKC sir, Jayaraman sir, Vijay Kumar sir, Jogani sir, Shubhu sir, Deepa madam, Kalyan, Dr. Kalyani, Sri Nandajan, and Srimati Vijayada Counts, the psychologist. Thank you.
Thank you, Dr. Ranjit. That was an excellent session. Next, our session is myths and facts about adolescent suicide. For this, we have none other than Dr. T.P. Jayaraman sir, President, IAP Kerala. I invite Jayaraman sir for the talk. Over to Jayaraman sir.
Thank you, Dr. Shibu. Can I share my screen?
Yes, sir.
Hope the screen is visible.
Yes, sir.
Visible.
So thank you, Ranjit, for the nice introduction of the plan as well as the issue of suicides in adolescents, and also to IAP Calicut for giving us this platform for the launch of this program. As Dr. Ranjit was telling, there was so many myths in the society and the public regarding the issue of suicide. And this is one problem which people don't want to talk much. Even if there is a problem of the suicidal intent and suicidal attempt, people want to suppress and people don't want to express it openly. So there are some important suicide myths which we all have to be aware. And this is the first topic of this TOT. First is people who talk about suicide never attempt or follow through with suicide. This is a belief among all of us that those who talk that I'm going to commit suicide or suicidal issues, they will just bluff it and they will tell you to get attention and they are not going to commit suicide. This is the number one myth that is wrong, and you have to take these expressions very seriously and you have to follow up them. This is one of the most important myths regarding suicide in the society. Number two is, if a person has attempted suicide, they will never attempt again. This is somebody with a failed attempt of suicide. It is actually a warning and it is a call for help. And this myth is absolutely wrong. An attempted suicide is a high risk factor and help is needed for these children. Third myth is people who say they are going to suicide do it for attention. This is also one of the common myths in the society, and this is absolutely wrong. Most of them talk about suicide to someone before committing a self-harm. Basically, it is a cry for help again. So don't be judgmental in these issues, and it is better to take the help of a trained mental health professional to assess their suicide risk by validated screening testing. and this is another common myth about this. This is once a person is suicidal, they are suicidal forever. This is also wrong. Uh, these children require biopsychosocial counseling. You have to go deep into the reasons, and they can be helped, and they have to be helped, and an appropriate referral to a mental health professional is warranted in these cases. And they can be sold. They can be helped to come out of the issue. Improvement following a suicidal crisis means that the suicide risk is over. This is also a mistake, and these children requires continued follow-up. Otherwise, they will land up in the same situation when a sudden issue crops up. Actually, every suicide, every successful suicide is preceded by 2 or 3 failed attempts. All suicidal individuals are mentally ill. This is also absolutely wrong. But all these children have to be screened for mental illness, like what Professor MKC was telling, for the presence of depression and anxiety and other issues like drug addiction, and all those things have to be screened. But it doesn't mean that all suicidal individuals are mentally ill. Every suicidal death is preventable. This is also absolutely wrong. You can make efforts, but sometimes it is beyond our reach. I still remember one father coming and telling me his wife had attempted suicide 2 or 3 times. He was on treatment. One day he came to my consulting room and told, "Sir, this time she failed me. I had been taking so much conscious effort to avoid this catastrophe, but somehow she failed me this time." If you ask directly, "Are you having thoughts of suicide?" you are putting the thought in their head. This is also not correct. Actually, children express this desire if you can have a rapport with them, you can empathize with them, Hope I'm audible now. I had a power problem.
No audible, sir.
Audible, sir.
Now audible.
So there is nothing wrong in asking the direct question, which I think Dr. Deepa and the psychologist Nandajan will be elaborating. There is nothing wrong in putting the direct critical question to these children, so that very often they come out these feelings, and there is nothing like you are putting the thought into their head. Actually, talking to a person about the possibility of the presence of suicidal thoughts in a non-judgmental manner and with empathy may provide an opportunity to vent out the pressing thoughts of self-harm and give a sense of relief avoiding a suicide, and it will give you an opportunity to involve, to help to reach to these children and to take them to a mental health professional in an appropriate way. If a person is going to suicide, then nothing can stop them. This is another myth. You should never give up. Expressing suicidality is a cry for help, and suicide is highly preventable. Proper attention to warning signs and risk factors will help this particular child to avoid the suicide. And actually, there is this are these non-suicidal self-injuries are a cry for help and warning signs where you have to involve so that the critical event can be prevented. The only successful intervention is that which comes from a pediatrician, psychologist, or psychiatrist. This is also wrong. Parents, teachers, friends, even religious leaders, counselors all can help. Only thing, they have to reach up to them. And actually peer group has got an important role in prevention of adolescent suicides. This actually we had as part of the program Changadi, which Ranjit had mentioned in the previous program. We were fortunate to train student police cadets of all the higher secondary schools of Palakkad in the year 2017-18, that period. And these children was a good source of help, because they were given training to identify the suicidal intents and help the children to reach mental health professionals. And this method was successfully trained with the help of Kerala police and student police cadets in the district of Palghat, which we found very useful among adolescent children. So the take-home messages of this presentation is: you should provide supportive environment to adolescents, be easily approachable, especially in stressful situations, show empathy and have an effective communication with adolescents, and identify the warning signs, act early to prevent the critical event. Seek professional help without hesitation. This is the program which Dr. Ranjit had mentioned in his presentation. This is an organization, a voluntary organization we formed in Palghat in the year 2015, and we had been in this field of prevention of adolescent suicides by involving in higher secondary schools, in involving counseling students with suicidal intents and suicidal ideations on a voluntary basis. And we could actually actually Nandajan, who is the last speaker of this program, is a psychologist. He is the president of the organization and he is one of the major contributors for this module. We could counsel about more than 6,000 children during a span of 3 years. And actually this COVID has literally slowed our activities. We have a strength of about 900 volunteers involved in this organization, and these volunteers are even after giving these counseling sessions, every school we have got 2 volunteers to follow up with these children, and this is a good social intervention we could do in the field of prevention of adolescent suicides in Palakkad. And this is our motto. നിങ്ങൾക്ക് എന്തോ പറയാനുണ്ട്, എനിക്ക് കേൾക്കാൻ സമയമുണ്ട്. Actually, we are not into counseling, but we call it as befriending. And this is what we follow in this adolescent counseling. I think Nandajan will elaborate upon it during his session of empowering the teens. And this is another important thing. You cannot just write it off like pote saramilla ellam seriyagum. You should never do that. You should take the suicidal ideations and suicidal intents as an important issue, and these children should be referred to mental health professionals at appropriate time. So this is all that I have to tell, and these are the contributors for the module. Thank you for this opportunity.
Thank you, Jerem sir, for this excellent talk and sharing the vast experience in the field of prevention of adolescent suicides and elaborating the voluntary organization Changadi. So next we going to the third session, that is the suicide prevention, pediatrician's perspective. We have an excellent speaker, Dr. Deepa Janardhanan, who is the treasurer of AHA Kerala and also our dynamic secretary of the organizing secretary of the Mental Health International Conference. Over to you, ma'am.
I'm not able to share the screen, Dr. Ranjit. I'm not able to share the screen. You're disabled, man.
Dr. Sabik, can you make Diva ma'am co-host?
I think you can try.
Yeah, now the screen is
Yeah, yeah.
visible.
Good evening, everyone. At the outset, let me thank IAP Kerala, IAP Kozhikode, and AHA Kerala for giving me this wonderful opportunity. We pediatricians start seeing human beings right from the point of birth. Imagine a newborn whom you resuscitated at birth. You took him to an ICU, and after an eventful NICU course, you helped him graduate out of the NICU. You monitor his growth and development. You immunize him. You treat his LRAs, his diarrheas, his urinary infections. He became a teen and comes back to you with acne. He appears a bit gloomy. You prescribe him comedolytics. And imagine after 2 months, you happen to meet his parents, who with utmost grief informs you that their teen son died by suicide a week ago. Friends, death registry studies have shown that 80% of the youth who die by suicide had a healthcare visit months or weeks prior to the event. That means the golden opportunity to save valuable lives have been missed. Moreover, the social stigma, as Dr. Ranjit was telling, attached to mental health consultations still prevail in our society. And we pediatricians having better rapport are in a better position to save these lives. Hence, my topic for today is suicide prevention in adolescents, a pediatrician's perspective. I'll be describing this topic under the following heading: role of pediatrician, primary prevention, secondary prevention, and tertiary prevention. Of the three, I'll be describing what they are, what are the strategies involved, and I'll also be telling about the screening tools involved. And finally, I'll be discussing 3 case scenarios. The first one will be of a teen who has attempted suicide. Second will be a teen with chronic illness. And third will be a case of non-suicidal self-injury. So the role of pediatrician. The first role is to foster resilience. What is resilience? In simple terms, resilience is the ability to bounce back from the adversities of life. And how can a pediatrician promote resilience? Pediatrician can promote resilience by highlighting the patient's strengths, encouraging self-efficacy, and identifying the protective factors like strong social connections, strong spiritual and religious beliefs, and engaging in mental health treatment. The next role is in detecting suicide risk. So pediatrician also helps in managing those who screen positive. We need to equip families of at-risk youth with safety plans. Lethal means safety counseling needs to be done. And last is connecting their patients to the much needed mental health interventions and treatment. So next is primary prevention. Primary prevention aims to prevent the onset of suicidal thoughts and behaviors. And how do we do this? We do this by fostering resilience in young patients, promoting peer and family connectedness, and intervening on parent psychopathology. Studies have shown that parents with psychopathology are more likely to have kids with mental health illness who are prone to suicide. So intervening on parent psychopathology can convert a risk factor into a protective factor. Now, secondary prevention is the intervention that is done after the onset of suicidal thoughts and behaviors. It's done by detecting the youth at risk for suicide and recognizing those exhibiting warning signs. We have a mnemonic for the warning signs. It's called ISPATH-WARM. I stands for ideation, that is threatening to hurt or kill self. S is substance abuse. P is purposelessness. A is anxiety and agitation, unable to sleep. T is a trapped feeling like there is no way out. H is hopelessness. W is withdrawal from family and friends. A is anger, excessive rage, recklessness, and high-risk activity. And M is mood changes that are dramatic. For this, we have the Ask Screening Toolkit. So it has the following things. First is a parent or guardian flyer. It is given at the front desk. So the parents, as Jairam sir was telling, usually have a myth that talking about suicide can trigger suicidal ideas in the teen. So this flyer states that it is actually a myth, and talking about suicide gives the teen a golden opportunity to ventilate his disturbing thoughts and an opportunity for us to help him. Again, parents many a time are unaware of the suicidal thoughts of their kids. So being aware helps them become more vigilant. Then there are nursing scripts which helps the nurses to know their function. Then we have the Ask Screening Questionnaire and Brief Suicide Safety Assessment Guide and Worksheet, both of which I'll be describing in detail. Then we have the Suicide Risk Screening Pathways, which are actually flowcharts. We have separate charts for youth and adults. And also there are separate pathways for different settings like OPD settings, emergency department settings, and also for IP settings. They also have COVID-19 suicide risk screening pathways or flowcharts, which are actually pathways for screening for suicide during the COVID-19 that's done over mobile or through teleconsultations. All these toolkit materials are available in the National Institute of Mental Health website. So the suicide risk screening pathways, which I was telling, is actually a three-tiered system. The nurses and the medical assistants administer the Ask as a brief screen. Then second is the mental health clinicians or nurse practitioners or the physician assistants or physicians conducting a brief suicide safety assessment. So after the screen, we have the assessment. And if necessary, there is a full mental health evaluation will happen. So this is the Ask Screening tool. This has to be administered to the adolescent, ensuring privacy. This is an evidence-based tool with a sensitivity of 96.9% and specificity of 87.6%. It takes around 20 seconds to administer. So it consists of basically 4 questions for which you need to answer yes or no. How do you ask about suicide to an adolescent? Unlike sexuality, where we ask indirect questions, for suicide, we need to ask direct questions. Let's see the questions in this questionnaire. The first question is, in the past few weeks, have you wished you were dead? Yes or no? The second question is, in the past few weeks, have you felt that you or your family would be better off if you were dead? And third is, in the past week, have you been having thoughts about killing yourself? And last is, have you ever tried to kill yourself? If yes, how and when? So if the patient answers no to all the 4 questions, it's a negative screen. But if he answers yes to any of these questions or refuses to answer any of the question, then we have to give him the next 5th question, which is the equity question. That is, are you having thoughts of killing yourselves right now? Yes or no? If yes, please describe. So if he answers yes to the 5th question, that means it's an acute positive screen. Means the child needs an emergency psychiatric consultation. He should not be left alone. His parents, his treating physician should be informed. And also all the dangerous means should be kept out of his reach. So that is an acute positive screen. But if the 5th question he answers no, but he had a positive screen for the initial 4 questions, then it is a non-acute positive screen where you need to do the BSSA, that is Brief Suicide Safety Assessment. So here we have the Brief Suicide Safety Assessment. Begin by praising the patient. Why should you praise the patient? We have to praise the patient for discussing their disturbing, difficult thoughts with us. The next heading is assess the patient, which has many subheadings, including frequency of suicidal thoughts, suicidal plan, past behavior. In past behavior, we need to ask about intent. How do you ask about intent? Do you think the means you have selected is capable of killing yourself? Or do you really want to die? So if he says yes, that means he has an intent. Next is symptoms, then social support and stressors. Until this point, you will be interviewing the adolescent alone. Now, with his permission, you invite the parent and you inform the parent that after discussing with your son or daughter, we came to know that he has such and such thoughts, and just ask them whether they were aware of it. Then we move on to the make a safety plan with the patient. And finally, it is determine disposition. The purpose of BSSA is to determine the further course of action in a non-acute positive screen. So that is the last step. So here we have a sample safety plan. It has for the following headings: warning signs, coping strategies, supportive people, and professionals. So warning signs that tell me a crisis may be developing, maybe situations, maybe thoughts, maybe images, maybe behaviors. So he need to write down what all are his warning signs. Next is the coping strategies that help me feel better. Sometimes it may be listening to music, maybe writing, drawing, going for a walk, talking to a friend. So whatever he feels like, he can write down there. Again, supportive people I have permission to contact, or places I have permission to go that can help me feel better. So the supportive people, he has to mention the names and the mobile numbers or contact numbers, and also the addresses. Professionals I can contact in a crisis: counselor, crisis hotline, school social worker. So all these things he has to write down, and this has to be agreed upon by the pediatrician, the psychiatrist, the patient, and the parents. So the last step of BSSA is determine disposition. So after BSSA, if there is an immediate threat to life, that means the child has a suicidal intent and a plan, then the patient needs an emergency psychiatric evaluation. As I told, he should not be left alone, and all the dangerous means of suicide should be kept out of his reach, and his parents and the physician should be informed. And if it shows that there are severe psychiatric symptoms, significant change in overall functioning, and a suicidal ideation, but no intent, no plan, you have a breathing space, you can refer within 48 to 72 hours. And the last is mild to moderate psychiatric symptoms without suicidal ideation, no non-urgent mental health follow-up may be done. And the last group may be no further intervention. So now, what are the challenges to implementing screening programs in medical settings? One is time constraint. Data from large screening programs reveal that screening has not added volume to the overburdened systems of care. There are studies from Texas where they have screened more than 2 million adults and kids. Managing patients who screen positive. Actually, over-responding to the positive screen can make any screening program untenable. So every positive screen should be followed by a BSSA to determine further course of action. Discomfort with asking questions about suicide. Actually, we had to do it in an adolescent-friendly way. Like MKC sir was telling, you need to do know a bit of counseling for this, and we should show empathy and being non-judgmental and ensure privacy. And stigma, as everybody was telling, stigma is there, but I think pediatricians are in a better position to talk to the teens. Now, tertiary prevention or postvention is actually the long-term response and plans to address the after effects and consequences of suicide for the survivors of suicide, friends and family. It helps them cope with the loss and to prevent cluster suicides and copycat suicides. So now we go on to the case scenarios. Our first case is a 13-year-old girl who was brought to emergency department. She was found to be drowsy in the morning. Her GCS was 9/15. Her respiration was shallow. BP was 110/70. She was confused with dysarthria and hypotonia. Her brother's anti-epileptic medicine strip was found empty. She was obese with hirsutism. So emergency care includes stabilize and triage, toxicology and psychiatry referral, and counsel parents regarding management. Inpatient care, close observation as she may reattempt. Explain risk to the parents. Keep all means of suicide out of reach. Pediatrician to team with psychiatrist. Before discharge, we need to do the risk assessment. We need to ask the following questions. How do you feel about being alive? Do you regret your action? Do you understand the consequences of your action? At present, do you have thoughts of ending your life? If you have similar thoughts in future, what would you do? What would you do differently? Before discharge, we should have the safety management plan. Parents are told about the warning signs of suicide attempts. Teens to be with family and friends most of the time. Teens should not get access to means of suicide, and safety plan should be agreed by teen, parent, pediatrician, and psychiatrist. And important parenting tips include actively listen to your teen. Be aware and empathetic towards teen stressors. Provide a nurturing and supportive environment. Encourage healthy lifestyle, adequate sleep, limited use of gadgets, regular exercise, healthy eating, and healthy friendships and family relationships. Teach life skills. So second case scenario is a 16-year-old boy, a known case of juvenile idiopathic arthritis for last 5 years on treatment, was brought to pediatric OPD with complaints of joint pain and swelling into 2 days. OPD management includes evaluation and management of JIA relapse. OPD nurse administered the ask as a brief screen. The 16-year-old boy marked yes to question 2 of ask of the above and hence was asked the following acuity question. Are you having thoughts of killing yourselves right now? If yes, please describe. He answered yes to question 5. So what's the further management? Stat, safety, full mental health evaluation. He's not allowed to leave until evaluated for safety. He was kept inside, removed all dangerous objects from room, alert physician or clinician responsible for patient's care. A third case scenario is 14-year-old Devika, who was brought to a pediatrician as she has been irritable at home and once yelled, I might as well be dead. Devika's parents divorced last year. While taking Devika's BP, it was noticed that she had several scars from superficial cuts to her left wrist. So non-suicidal self-injury, as Jaraman sir was telling, it's actually a cry for help. The superficial cuts or injury are done to relieve stress and anxiety, usually have no intention of ending their life. It's a feature of personality disorder. You need to assess thoroughly for suicide risk, and treatment is basically counseling. So just to remind you, the HEADS evaluation of adolescents, H stands for home, E for education, again E for eating habits, A for activities, D for drug use and depression, and S for suicidality, sexuality, and safety. So we did HEADS evaluation for Devika. She was in a relationship with a Facebook friend who is not reachable now. Did not want to end life but felt sad as her parents had also separated. Has supportive friends and is religious. She's good at drawing and wanted to become an architect. So her protective factors are good relation with peers, religious, special talent of having drawing, and she's ambitious of becoming an architect. Risk factors include learning disability, corporal punishment, low self-esteem, and poor life skills. So adolescent suicide behavior should be referred to a psychiatrist, and other types of referral we already mentioned. School support, mental well-being, life skill education, and building resilience to be added to the school curriculum. Advocate for school counseling centers. School counselors and teachers are gatekeepers for mental health. And postvention is required if suicide occurs in a school setting. Community participation. Pediatricians need to partner with government, NGOs, media, social networking sites, police, religious faith leaders, and lawyers. As you all know, a child helpline number is 1098. Disha helpline is 1056. The Chiri is an initiative by Kerala Police, the helpline number being 9497 900 200. So all these numbers should be given to the patients who comes with a positive screen. And September 10th is celebrated as the Suicide Prevention Day by WHO. So key messages: suicide is preventable. Adolescents should be screened for suicide risk. Pediatricians should partner with mental health professionals, parents, teachers, and adolescents to manage suicidal behavior. It is essential to promote positive mental health to ensure adolescent well-being. These are my references. Here are the contributors. Thank you.
Thank you, Diva ma'am, for the excellent talk and interesting case scenarios and approach to adolescent suicide in a pediatrician's perspective. Now it is the last session of today's talk, that is Empower the Teens by Sri Nandajan K. He says basically psychologist. He had done his BTech and he also done his MA philosophy. He is a wellness coach and a corporate trainer also. And he's the present president of Changadi Trust, as Jairam sir mentioned. Over to you, sir.
Can you make me co-host?
Sure.
A warm good evening, dignitaries and office bearers of IAP, and ladies and gentlemen. I'm happy that IAP is taking serious steps on adolescent suicide prevention. This is an area which is not sensitized properly even now, I believe. As a couple of times it is mentioned about Changadi. Changadi started functioning in 2016 and it is registered as a trust in 2019. That is why that number, registered number is with 19, but we started working, functioning since 2016. A group of like-minded people started functioning that one. Dr. TB Jairam is there, myself is there, and here in the Zoom room, Vichita Prime Sundar, psychologist, is there. Vichita, can you switch on your video for a time being? She contributed for the material preparation also. Vichita, are you there? Hello. Okay. Now, why it is not sensitized in the required manner means because, as we all know, the number of people dying in road accidents is somewhere around between 4,000 and 5,000 over a period of year. I am not giving the exact numbers. But number of people suiciding or number of people commit suicide in a year is on an average 8,000 to 10,000. That is roughly double the road accidents. But people are not knowing that. There are a lot of safety measures for the road accidents, but when people commit suicide or the amount of suicide happening in our country or in our place, the proper sensitization is not happening that way. Even in the last year, during the lockdown initial period, for the first 100 days when 86 suicide were there, or adolescents committed suicide, people started worrying about that one. And that's why that study happened, which is already mentioned here. But in the previous year also, a similar, actually the number is a bit higher than that in the similar period. So that is why I told you it is not sensitized properly. Okay, now people are talking about that one. That's good. At least people started thinking, or whole missionary is thinking on that one. That's good. And what we can do in our practice, as we all know, already mentioned a couple of times in this meeting itself, we are working a group called Changadi, which is working specifically on adolescent suicide prevention. We meet higher secondary school children and we do befriending, that is active listening to them. And altogether, we have conducted, actually, I will share my screen for that statistics, which we did that one, just a minute. Yeah, that is. We are actively, or our activities are mainly focused on Palakkad district and Malappuram district. And this is the statistics. Totally, we have gone to 116 schools, and from 2015-16 to 2019-20, 5,454 cases or successful intervention done, and out of which high risk level is 113. High risk means, as per the UN norms, the suicide risk is high risk, mild risk, and no risk. This is the way the risk pattern is given. High risk means they have committed or they have attempted suicide at least once. So based on that experience and based on the psychological studies, let me go through some of the psychological aspects of suicide. Prevention of adolescent suicide. Don't be afraid, you're not alone. But this is the message that we need to pass to those people who are having suicide ideation. That is, you're not alone. We are there, or we are with you, or there is somebody to listen you. That is why that motto itself is നിങ്ങൾക്ക് എന്തോ പറയാനുണ്ട്, ഞങ്ങൾക്ക് കേൾക്കാൻ, എനിക്ക് കേൾക്കാൻ സമയമുണ്ട്. It is not ഞങ്ങൾക്ക്, it is എനിക്ക് കേൾക്കാൻ സമയമുണ്ട്. That means it is a personal talk on that one. Okay, that is, can we prevent suicidal events? That is the first question. And as you all know, everybody know that one because we were deliberating on that one. The answer is yes. How it can be done? By empowering teams. Empowering for what? Empowering to face failures in the life, go through the failures in the life, and handling or facing the life issues, problems, for which we have to empower the teams. And if you empower teams, in fact, we are actually rescuing, or we are saving a generation. If these teenagers or these adolescents, if they are empowered to face the failures or problems of their life, in which we really saving a generation. And steps in empowering, how we do or how we can do that empowering. That is, one is the wise use of media, stress management, resilience. Resilience is already mentioned here in this speech, and life skill education. We need to go through these steps. Okay. Now, mental health is the key. Actually, in our society, we pay a lot of attention for physical health, especially in Kerala. We know that on all the health indexes, everything are on the, we have high indexes on that, because we pay a lot of attention for our physical health. But what about the mental health? Even meeting or consulting a mental health professional is a taboo in our society. Here, life is full of challenges and various stresses for teenagers, and life skill act as a vaccine against external influences and internal emotional turmoil. Life skill training is a must, and how we can do that, we have to find out ways and means how it can be done. Life skill education by parents and teachers nurtures a mentally strong, resilient, and responsible team who can handle stress and challenge effectively. Life skills should be taught to children. Many times our focus of attention for the education is moving away from this kind of things. We have an incident that is, there were in Palakkad district, there was a school when a student failed in the 10th examination, the headmaster has to give a lot of explanation in the following year for the failure of one student. In the same academic year, 2 students committed suicide in the same school. Nobody asked why. So the focus of attention of school education is converging to writing the examination. It should not be like that. School is not for writing examination or for what do you call, learning the subjects alone. We have to imbibe, or we have to take care of life skills also in the schools. Now, what are all the life skills? I'm sure you all know that one. These are all the listed life skills. That is, one is the self-awareness, decision making. Yeah, this is the major area where people find it very difficult on that one. But in case those who tried for suicide or attempted for suicide, when they come in front of us, we used to say, good, because it is good. You attempted or you tried like that, yeah, it's good, because you have the capacity of decision making, and that's why you did it. Okay, next time you can make use of the same decision capacity for something else. That way we can go that one. Okay, that is critical thinking, coping with stress, handling emotions, effective communication, nurturing relationship, personal safety, goal setting, of course. Why that is wise use of resources, whatever it is available for us. So these are all the life skills available, and we need to teach life skills. And life skills make our thinking protective productive, peaceful, and pleasurable. If we are able to do that one, even you can see that the people who have very good at academic or having good academic career or professional life, but when you go for the life skill, people are lacking in that one. Not everybody, some of the skills are lacking. And here, how to make your team life ready. That is cultivating resilient teams. Resilience is already mentioned here by previous speakers. That is the way that we have to go. Still, let me just go through that one. That is, resilience is the capacity to handle changes or adversities. Like other skills, it changes with experience over time. Resilient teams have high frustration tolerance, resistant to tantrums, mood swings, and stresses. Of course, all the mood swings, everything which is related to depression and everything. When you have or the resilience is developed, they can handle it themselves, make healthy choices from available options, are flexible, approachable, and admired in the group. That is the quality if you have resilience or if you develop the resilience. And mechanism to enhance resilience, how it can be done. Social and emotional learning is there. Positive psychology is to be there. Mindful approaches is there. In positive psychology, you need to have a goal setting. You have to work for the goal. You have an action plan for your goal, your personal life goal. It goes something like that. And tips for parents and teachers. Yeah, they have to play a vital role. That is parents and teachers. That is role modeling desired behavior, follow authoritative parenting style. I'm sure you know what the difference between authoritarian and authoritative parenting style. Authoritarian means the parent dictates everything and child need to obey that one. Authoritative means it's a democratic kind of thing where discussion is possible, where both sides are discussed and finally going for a conclusion. A more democratic kind of thing where the children is listen carefully, not ordered. Saying no with proper explanation. It doesn't mean that it's a permissive parenting style. Whatever child asks, we agree. No. Saying no is important, but the way you say no matters. It's not with emotion, not with anger. It is called firmness without anger. And say, this is no. If you are denying mobile phone for a child, explain the reason why I am not providing mobile phone for you just because of this reason. That is saying no with proper explanation. Appreciating desired behaviors. In all psychological development or psychological theory says, behavior is reinforced by appreciation. Or where you focus or on which behavior you are going to focus, that behavior or that action will get repeated. Even if you scold, that is a sort of appreciation. It's a negative appreciation. That action will get repeated. There is a tendency to repeat that action. So that is why whenever the child exhibits, shows any positive behavior, appreciate that behavior, there is a tendency to repeat that behavior. And that's how parenting or good behaviors are cultivated. Now moving to teaching to accept failures. Again, this is one maybe just a kind of myth or something that always children are asked to be successful. Everybody says about success, success, success. In my view, we need not teach success. You teach handle failure, facing failure, going through the failure, accept failure, and learn from the failure. If somebody is taught to learn from the failure, accepting failure, going through the failure, success is a byproduct. You need not focus for that. Because in many cases, we know we have to go through the ordeal of failure, then only we reach the pinnacle of success. So you need not train for the success, but train to handle, go through the failures. Avoid constant criticism. Instead, appreciate whenever the desired behavior is there. Nagging or too much preaching, humiliation, preaching and advising, everything is will not give good results. Humiliation, empty praise, physical abuse, over expectation. Avoid empty praise also. Appreciating means it should come from the heart. It should be based on the things the child did, based on his or her action, deeds. Not empty praise, you're smart, you can do everything. That won't work. Yeah, you have done this particular thing. I appreciate that effort. Tell something like that. When the child comes with a very good mark, don't appreciate on the mark. Tell that I know you put a good effort on that one. Because that effort is to be reinforced. Not getting marks, something somehow getting mark is not a factor to be appreciated. Instead, the effort taken to get that mark. So even if he's not or she's not scoring good mark, but when she or he is putting good effort, we can appreciate that one. You have put good effort. I appreciate that one. Try to do more if you want to get more results or something like that. It goes something like that. Adopt a positive discipline techniques, encouraging skills participation in sports or extracurricular activities so that they can, more social skills can be nourished, encouraged. And stress management, I will just go through this one. This stress is the way our body and mind reacts to demanding life situations. Stress is not a bad thing. As we all know, there are positive stress and negative stress. Positive stress is a must. Otherwise, this positive stresses will give good results, better results. What we have to handle is the negative stress or the distress. Now, stresses are events or situations that cause stresses. That is the stressors. These alter the internal homeostasis status of our body. Internal stressors are within the body, like it can be pubertal changes or sickness or injury or malnutrition or sleep deprivation. So we need to find out what exactly is the reason. External stressors can be our outside body, like family stressors, peer pressures, or societal expectations. Even high expectations will also give a lot of pressure. And importance of counseling. And I am happy that Dr. MKC Nair, in his speech, he mentioned about need of training on counseling skills. Counseling here, it means the non-directive counseling or psychological counseling. Even many of the professionals are not aware of the real kind of counseling. Many even now believe counseling is giving advices. In a non-directive counseling or in a psychological counseling prevailing right now, it is not giving advices. Actually, counselors speak less and the counseling speaks a lot. So it is through counseling, early recognition of mental health or disorders in adolescents important. Parents and adolescents prefer to consult a primary care pediatrician. So basic idea of counseling is essential for pediatricians also. Basic thing, how it is. They need not be the counselors, but at least they can have the basic skills, which will definitely help them. And the difference between guidance. Guidance means you can give advices, making choices, decision in normal individuals in difficulties or confusion of choices. When there is a confusion of choices, you can give advices. That is coming under the guidance. Counseling is focused on the problem in a disturbed individual, stress-related crisis. The problem is focused, and I'll come to that one later also. Psychotherapy, restructuring of personality in mentally disordered individual need drugs, other therapy. There are therapy based on drugs also. There are therapy without drugs, which is for something like CBT, cognitive behavioral therapy without medicine. That is also there. And aims of counseling, that is to help the individual to assess the situation and choose the option. Here, help the individual. Not we are guiding, we are not telling them, we are not advising them. The individual or the counselee assess the situation and choose the option best suited for self and others. This portion is to be done by the client itself, and the role of counselor is to empower the client or the counselee to this level, to help adolescents become self-sufficient, self-dependent, and self-directed for a meaningful and fulfilling life, to bring about a voluntary change for improving personal effectiveness. These are all the aims of counseling. Now, effective communication and listen. There is we need active listening training. That is, we have to give them our time. It may take a lot of time. It may take hours or 30 minutes, 45 minutes, it go like that. But in the communication, we can understand their communication through their verbal choices. It can be in when we listen, it must be non-accusing. Tone and pitch should be in that way. Apt words should be used. Open-ended questions. We have to ask open-ended questions. What is your life plan, or what was the issue, or why did you choose such a path? Something like that, an open-ended question, not the yes or no questions. And of course, there are a lot of non-verbal cues also there in the communication, that where we have to have the eye contact throughout the active listening. Like that, it goes. And there is an approach that is called gather, or approach to counseling. Greet and introduce. When the patient or client, whoever it may be, initially to make a rapport, we can greet and introduce.
Is there a power failure, sir?
Hello, am I audible? I think here there is a power failure. Am I audible?
Yeah.
You are audible.
Okay. I'll finish within another 5 minutes. Just a minute. I'll share my screen because power is gone. Okay. I have almost reached here. Yeah, that is greet and introduce. Ask and listen actively. Listen actively means we are not asking, we can ask open-ended questions, and whatever they say, we can listen actively, as mentioned in the communication slide. Tell the relevant information, if any. Help in exploring options and action plan. Help in exploring options. We are not giving, advising the options. Let them develop, or let them say, once if they ventilate their emotions, if they ventilate their emotions completely, they will be able to look into their problem in a different angle. That will definitely help them to explore the options. Explain and review the key points. Return for a follow and references if it is required. When need urgent referral, death wish is revealed through talking or writing or texting the media. That is the urgent cases, collecting pill, weapon, drops, or searching for suicidal methods, indulging in self-harming activity. These are all the area when we need urgent referral, dangerous behavior to others, violence or aggression, or this one, addiction to alcohol, or this one. How to help? It is essential that you take suicidal behavior previous attempts or seriously, don't hesitate to bring up the subject suicide and to ask the direct question. Actually, it is already discussed here. Asking directly is a must in the process. Actually, when you ask direct question, then only in many cases they come out with the real reasons. It is important to seek the professional help for the adolescents, pediatricians, psychiatrists, or this or all this one. And how to help? Telephone counseling can be there. Suicide hotline services are available in most cities, or this one can be found in the telephone book. Most important to listen to their words with compassion and concern. Screening programs that seek to identify and this one. Media guidelines for sensitive reporting. Yeah, it is already mentioned in the initial talk itself. What should be the guidelines in the media? These are all the contributors for the module preparation. Thank you. Thank you for giving me an opportunity. And sorry for the technical glitches and the power failure issues.
Thank you, sir, for the enlightening talk and sharing your experiences. And I must thank all the contributors who contributed to this module. And I next invite MKC sir for his valuable comments.
I think before me, if Preeti is available, ask her to comment first, because she is an external guest.
Preeti ma'am. I think madam is not there, sir.
Okay.
Yes, left type.
Yeah. Okay, then again 5 or 6 points like I would like to highlight. Number one is Ranjit actually talked about that suicide death has come by crime record, which is a crude index only. It's actually talk about death, and particularly it's all age group. But what we need to have data is attempted suicide actually is increasing. I think we need to get some data and correct on that. Let that be correct. But on the other side, attempted suicide increasing. None of them get reported, especially because now it is not medical legal. So I think we should not say, give an impression that things are better. No, things are not better. Number one point. Number two is we need to create a network of supporting staff. IAP cannot do everything yourself. So what we can make use of available psychiatrists, friends, psychologists, clinical psychologists, but much more than that, the school counselors, because I have been continuously giving training for them. I know that they are suffering a lot because in the schools, because they have so much of problem, they don't know what to do, which includes even medical. So we can be a support to the school counselors and through them, the teachers. And as I think in the Changadi program, they were saying to train people. This is what I did in the university. 320 colleges, I had 2 teachers trained, very well trained. They were given a course and they certified in that. And every 6 months, one clinical psychologist used to go and review all their problems. And most of the places, as Vice Chancellor, I went there. What did I learn is that these teachers also get stressed up too much, because suddenly they were not doing such things. Suddenly they are bombarded with problems which they never thought of. They themselves need counseling. So that is another thing. The support of senior pediatricians. And I always say senior pediatricians who have already achieved something in life, they can have much more relaxed interaction with these people. The third one is we need to separate risk factor from precipitating factor. In adolescent thing, it's not a risk factor alone. If you have so many, I may have 20 risk factor, but I won't commit suicide. Simple as that. because I'm just not going to do it, I know. Religion sometimes can be protective. For example, Muslim community, by religion, they will not do it. Riyaz, am I right? Riyaz, am I right?
Sir, yes, that is true.
Yes, we have actually data to prove this from areas. The religion may tell you that you cannot take the life that God has given you. So that is a protective factor. But precipitating, because most of the attempt occurs on some spur of the moment, some precipitating factor. One bad word used by the teacher, one bad word, insult made by the parent. But already they were they already have depression, they already have many problems. But what precipitated this event, I think we need to talk a little more on that. Then one more thing we need to say, and after having done 40 years counseling and seen more than 60,000 children, one thing I am very sure that the diagnosis of depression is difficult in an adolescent, because most of them don't look depressed. They will come with such a style, to cover up all the depression. They will act out lot of acting out. So unless you are very careful, so what I do normally is, after listening to all their drama, I look into the eyes and said, Malak, ഇതൊക്കെ പറഞ്ഞത് സത്യമാണ്, പക്ഷെ എന്തുകൊണ്ടാ പിന്നെ കണ്ണിൽ ആ കരച്ചിൽ വരുന്നത് എന്തുകൊണ്ടാ? Why are you suffering so much? Just ask that question. Why are you suffering so much? Suddenly they will start crying and they blurt out so many things. So I think we need to mention something about that adolescent depression diagnosis is little difficult. We need to be little more ingenious, because they will try to cover up. They feel bad to show that I am depressed. Now, TSQ, one clarification, the actual screen questionnaire that is published in the in Indian Psychology Journal is screen questionnaire, which has 26 items. This is a abridged version. There is a long version, short version. You can go into the psychology, but this is an abridged one because this was done without any statistical method, but I found this useful. And we have collected data of 1.5 lakh adolescents across Kerala, every panchayat. One Anganwadi per every panchayat area we collected, and out of which the perfect 75,000 around that we are going to publish in Indian Journal of Pediatrics. Very simple screening. 3 things need to be clear. And this is something very important. We need to emphasize little more. 3 things first you have to ask. Do you have feeling sad? Yes. You feel crying? Yes. We all do that. It only means you are alive. But is your problem out of proportion to the cause? Number 1. If it is, then step 1. Does it produce definite body symptoms like palpitation, etc. in anxiety, sleep disturbance, appetite disturbance, and libido? Adult, you can ask libido. Small children don't ask. Libido means the sexual interest. So these are 3 very classical questions. In a school child, you don't talk about libido. You can say, have you lost interest in things you have lost previously? You are interested previously. So just ask these 3 questions. You know whether he is having anxiety or depressive symptom like. Don't make any diagnosis. But once you know there is a possibility of depression, ask these 3 things. Worthlessness, feeling always. The hopelessness, feeling always. Helplessness, always. Have you thought not worth, life is not worth living? Then any suicide. So a simple way of doing, and this I have practiced for so many years and I find it so simple. The actual validated tool is much bigger, but I find this much more simpler than that one. So the last message from the last speaker, the very respected psychologist, who really, I must congratulate him for doing the Changadi program. And from among all the points that he said, I think what most important point is, all of us need little training in counseling. Because unless you do it, you won't know. See, like for example, now Riyaz is sitting there. I also know endocrinology. But if you are not doing it every time, suddenly one child comes you don't feel like how to go about. You understand the difference. You know cardiology, but you cannot do cardiology just because you learned in MD. So but counseling is something we never learned in life. So some level of counseling, and we are trying our level best to bring under National IAP program, Adolescent Health Academy, counseling courses in distant mode. We are trying to do that. I think Academy has agreed it, but then there are some, procedural issues. So with that, I hope this will be done. And I must thank all, everybody, include particularly Ranjit, and also say my PS, Dr. Mr. Ashokan has done all this slide, beautified it and all that last night. Whole night he sat and did it on my request. So I must thank him also for that. So thank you all very much, President. You have done a wonderful job. Ranjit, you have done a wonderful job. Thank you. Thank you.
Thank you very much, sir, for your contributions and your guidance. It is always an inspiration for us, sir. Yes, sir.
Thank you, MKC, sir. Actually, in our Changadi program also, we are doing a review by these designated counselors and those who go for this counseling in higher secondary schools, for them an opportunity to vent out their feelings. And we had review sessions every month when we were active. Actually, before this COVID season, every one fixed day, one fixed Sunday, we had been doing the review of these counselors, which Nandajan will elaborate a little more, I believe.
Now, what I was saying, this hand-holding of counselors is so important. Don't put them into an ocean and say you swim. They can't. They have some training, not that they don't have training, but they don't have the practical feeling. So at every point, somebody need to handhold with them. Then only they will be able to improve from, step by step. Thank you.
Exactly, sir. To adding to that, continuous updation is required. So continuous review training is required, even though they are in the same field. And another big question, who will heal the healers? These school counselors and counselors are in severe stress on the other hand. So when we discuss together, one counselor can listen to the other one. So a ventilation of that kind is also required. Because since these people are going for the befriending, they have a lot of mental stress out of this particular process itself. So who will heal the healer?
Sir, in US,
that will happen in the review meeting. Yeah.
Sir, in US, every 6 months, the qualified counselors have to go for counseling.
Definitely.
There's a system. If you are a practicing counselor, you have to go for counseling every 6 months. Make sure that the question that you ask. And here the issue is they are facing all this problem. The school counselors have great difficulty. On one side, the law says that everything has to be reported. On the other side, the school will say don't report. And the third side, the parents will come and have emotional wrecking of you. They'll say don't spoil my child this thing. How do they are little young girls, how do they handle all this? So they themselves have problem. That's why I said we need to have hand-holding. Yeah, Dr. Jayaraman is a very senior pediatrician. He may not be a counselor, but because of his seniority and his experience of community, he can be a counselor for these girls. Not because he knows the subject so much, but because of his experience, community experience. So like that, senior pediatricians can help these girls, at least listen to them, actively listening to them, appreciating their problem, and that will help. I'm sure you must have got the same thing in your Changadi program, because don't let loose these girls into the community without back support. That's the point I was saying. Thank you, sir.
Thank you, sir. And I would like to welcome Dr. Riyaz, sir, our vibrant past secretary of IAP Kerala and EB member of Central IAP for his comments.
Thank you, Ranjit. Actually, I knew that Jayaraman sir has this dream project in his mind from many years. He had talked about this when he come for learning disability classes. So actually, this area that prevention of suicide in adolescents is something which is neglected. Like MKC sir told, we see, I'm also a teacher. So I never teach my students about counseling. So I don't think it is happening anywhere in our curriculum. So like sir told, it should come at least after getting an MD. We should have a certificate course or a short course for counseling. It is very much needed. And regarding the school counselors, actually, I was also involved in the training which MKC was telling. These counselors are very much receptive. They are ready to learn. So if we help, because I actually took a class on growth assessment and concerns regarding puberty and all. So they ask very intelligent questions, and I think we can use them with our guidance. They will do an excellent work, and they can prevent, they can identify depression, and they may prevent a few cases of suicide. So all the best, Ranjit. Actually, I want to congratulate Ranjit because his presentation was excellent, and he has a, a passion on this subject, and he has been conducting many sessions. Thank you all. Best wishes. Thank you.
Thank you, sir. And I would like to welcome Srimati Vijita. She is one of the contributors for the module. We want to hear from you, ma'am.
Thank you. So it was a great session, an enriching session, especially from our daughter MPC Naya. Thank you for the support, and Dr. hats off to you for this wonderful coordination and presentation. All the relevant points we discussed here are very useful for our adolescent students. Diba madam did a great job. What a dedication and passionate presentation, ma'am. Thank you. And Dr. Jayaraman, my godfather and my boss, he's the person behind all this suicide prevention. Thank you, sir, for your wonderful initiative, a real role model for all the beginners like us. And Nandajan, my colleague, he also did a great job. And my part is who will heal the healer, like that. We have to find a time to relieve our tension and stress among us. That's the most important thing. As a professionals, we all have the stress and tension and anxiety. We have to find out to call our friends at least for 2 minutes or 3 minutes. How are you, dear? What was the things going on? This was the first step as a trainer we have to do. We have to find out our timing for doing a small active listening technique. Practice from our own home and from with our colleagues and with our rest of the team members. That was the first step, and with this we can move forward. And all the best for the whole team, and we as a Changadi, all the volunteers will be with you, all the team IAP, and hats off to IAP team. Thank you. Over to Dr. Ranjit.
Thank you, ma'am. Vijay Kumar sir, the president-elect.
Hello. It is a wonderful program, and I think for the last 20 or 30 years I was in IAP, and this is the first time a very novel idea about suicide prevention, and I am very happy that I can also read the module and give some comments regarding the module, because Ranjit has given me at least 1 week back, and I am very happy that I was also doing a small part of this very good initiative. I'm very happy and wish that it will be a great step in IAP. Thank you.
Yes, Ranjit, I have a suggestion.
Yes, sir.
There are lots of people in the community who actually want to be counseling volunteers. Many with good intention, some with bad intention. It is possible. Just think, I think Jairam sir is there, I think. IAP can think of doing a webinar-based certificate program, for these people. I'm not saying for school counselors because they have professional training program organized by the government. They also can join, but if you say for them, you may have to go for government permission and all that. But there are lots of people in the community who actually wants to be, you designate them like volunteers, something like that for school children. The problem is so huge, the number of people involved are so few, but we need to have group. But only thing is we make sure that tomorrow they should not act like clinical psychologists and all that. That's why I said some voluntary. If you can identify a better word, don't want to say lay counselor, but you can say some word we can identify. Have a 1 month program in which, because now the schools are all closed, nothing is much happening because other things. So this is one thing you can think of. Just think of it possible. I'll be willing to help. Okay.
Thank you for the valuable suggestions, sir.
The problem is somebody has to certify it. Only professional organization can certify. IAP in the name of Adolescent Health Academy can certify. Because professional organization can certify anything. Certificate program particularly, not degree, super degree, but certificate program they can. So for the people in Kerala, you will have a network of people working with adolescents. Just think of it. I am saying majority will come with good intention, but there could be few with bad intention also. That also we need to be careful.
Sir, can we involve the RKSK nurses coordinators and if there is any?
No, we can. In fact, the people who in the ICDS, they are RKSK when they are doing, they all want somebody to train them. Only thing, and if it is academies asking, the director of social justice welfare, actually, madam is very keen to do some of these programs. Okay. So only thing is, if individual do, it's different. But an organization do, particularly AHA under the banner of IAP AHA, then it will be a professional body. You can talk to Anupama is a secretary now. So it may be a nice thing. We can organize and I can help you whatever you want.
Okay, sure, sir. We will coordinate. Jaram, sir.
We will plan it, sir. I think it's a good idea and it is required. What we have experienced in Palgad, it's a good experience.
I think you can do it. And one comment to Deepa, madam, you have done a wonderful job, but I think few of your slides may be cut and give more importance to that case scenario. Okay, spend little more time with the case scenario, that you actually spend bring in little discussion on those things. That will be good. The initial slide, few of them you may cut it, but give more time to the case scenario, which is beautiful one, because that is what make impression in people. Okay, I didn't want to cut it because it didn't look nice. You have made it and I cut it, so I didn't make any change. But I think it may be nice to reduce the theory part little and go into practical. Okay, madam.
Thank you, sir.
Okay, thank you, sir. And now it is coming to the end of this excellent session. I would like to invite our dynamic secretary of IAP Kozhikode, Dr. Ajay, for the vote of thanks.
Thank you, Dr. Ranjit. Firstly, I would like to thank Dr. MKC Nair, sir, our chief guest, and for concerning for inaugurating the presidential action plan. Thank you, sir. So it has been it's a privilege to hear from sir, and all the directions and guidance from sir will be definitely useful for the AHA and IAP in the coming years. And I would also like to thank Dr. Jayaraman DP, President of IAP Kerala, for bringing out such a very nice initiative of suicide prevention in adolescents, which is probably one of the neglected areas. And it is our responsibility as a pediatricians to make sure that we carry out these things. And also like to thank Dr. Shibu K, Chairperson AHA Kerala, and our Dr. Vijay Kumar sir, President-elect IAP Kerala, for his valuable comments. Dr. Narayanan sir, IAP Kerala President 2020. Dr. Joni Sebastian sir, Secretary IAP Kerala, for felicitations and valuable comments. And it has been an excellent scientific session by a great team under Dr. Ranjit, Chairperson Suicide Prevention in Adolescents, and Dr. Jayaraman sir, and Dr. Deepa Janardhan, and by Dr. Sri Nandajan. And it has been a privilege of IAP Kozhikode to host the program on behalf of IAP Kerala and AHA Kerala. So thank you everyone for your kind participations and valuable comments. Also, thanking all the senior faculties and members of IAP Kerala and National EB members, Dr. Riyaz sir, NNF President Dr. Devi sir. Thank you everyone for the support. So thank you, everyone.